Hi, my name is Mr. Catheter and I'm going to talk about catheter ablation of ventricular arrhythmia. First of all, we have to talk about the main pathology of this surgical procedure, that is ventricular tachycardia accom- accom- with characterized with for a tachyarrhythmia. The definition is that it is a cardiomyopathology that arises from an abnormal electrical focus or circuit in the myocardium of the ventricle. It is usually manifested as a tachyarrhythmia with a wide QRS complex. This could be with or without clinical consequences that comes from dizziness to syncope or sudden cardiac death.
Today we're talking about the second most deadly rhythm ever. The second of only two rhythms that we defibrillate or shock. The other is VFib. Now, what exactly is VTach? Ventricular tachycardia is a very fast heart rhythm that begins in the ventricles when both the SA node and the AV node fail to generate an impulse. The ventricles will assume the role of pacing the heart. So what is really going on in the body here? Well, as you know, the heart has one main pacemaker and two backup pacemakers. In this case, our main pacemaker, the SA node, and our backup pacemaker, the AV node, have lost control at boss pacemakers. But the difference is that VTach is a little bit more controlled than VFib. But guys, either way, the ventricular pacemaker cells are having a party. They're causing a ruckus and they're pretty much acting a fool and not pumping effectively, leading to no cardiac output, basically no oxygen to the body, and your patient is going to be dead soon. Using our 5 steps, let's interpret this EKG. So step number 1, the rate is going to be 100 to 250 beats per minute. It's pretty fast. The rhythm is regularly spaced and even like tombstones, so it's unlike VFib that's chaotic and crazy like fireworks. Now the P wave, there's going to be none because the atria are not contracting. The PR interval, there's going to be none again, guys, because the atria are not contracting. Now the QRS, this is the really big landmark. It's wide and even like tombstones, and not like VFib, where you pretty much have no QRS. So what are the main causes of VTach? Well, guys, let's think about the patho here. All the main causes stem from a dysfunctional contraction of the heart. So this can be from stimulants or stress like caffeine or drugs like methamphetamines. They make the heart contract way too fast. Medication toxicity like digoxin, something called digitalis toxicity, or electrolyte imbalances like low magnesium or low potassium. This causes the heart to have less control and pretty much contract erratically. Now lastly, the cardiac injury, so history of MI or heart attack, basically has a loss of tissue function, meaning we have big pump problems. Now, signs and symptoms for VTach all stem from an oxygen problem, basically low cardiac output. And just like in VFib, but the big difference is that our patients are mostly awake. So we'll see complaints like chest pain, oxygen saturation that is lower, L is for lethargy or fatigue, A is for anxiety, basically anxiety from having no oxygen, P is for palpitations, which is just a racing of the heart. It kind of feels like gallops under the chest. S is for shortness of breath or dyspnea, that difficulty breathing. E is for elevated heart rate, now except in third-degree block where the heart rate is usually lower. And D is for dizziness and syncope, which is also called fainting or passing out. Ultimately spiraling into VFib, then cardiac arrest, and then death. So what are we going to do about it? Now guys, before you start memorizing all of your nursing interventions and treatments, just slow down and think. What are the main patient outcome goals? Well, it's always to reset and restore that normal electrical conduction. So we're first going to assess the patient, guys, because assessment always comes before nursing interventions. So that's a huge NCLEX tip. So if your patient has a pulse, then guys, we're going to give them amiodarone to stabilize that rhythm. And then deliver a little baby shock called cardioversion, which is 50 to 200 joules of electricity. to reset that SA node, that main pacemaker of the heart. Now, if the patient has no pulse, well then, grab a crash cart, call a code, you start CPR, go to lunch, pay my bills! Ah! Okay, well, maybe not pay the bills part, but we're gonna start immediate defibrillation, that supersized shock. 200 to 360 joules of electricity. The main goal is to reset that SA node. Then we're going to give lidocaine to relax those crazy ventricles. Then amiodarone to stabilize the rhythm. Then follow normal cardiac arrest procedures. Thanks for watching. For our full video and new quiz bank,
Then we have to talk about applications in medicine. That is, here I refer to the procedure that is catheter-based management of ventricular tachycardia. This was inspired by theoretical studies which showed that resection of the myocardial scars could result in control of the ventricular tachycardia. Successful catheter-based ablation of ventricular tachycardia was initially reported in 1983, and its use has increased in the past 2 decades with development of radiofrequency ablation in the 90s. Catheter ablation is typically considered of the treatment of ventricular tachycardia when drugs are ineffective or have unacceptable side effects.
If the patient is having rapid heart rate, so there is a good option to be able to fix it. Majority, almost all of these arrhythmias, we would be able to do catheter ablation. If we go through the groin, there are two big veins, which are femoral veins. They are like about 1 or 2 inches each one of them. So we put the catheters through the groin, and these catheters go through the inferior vena cava. These catheters that I have, they have some electrodes, some platinums on it. This platinum, when it comes in contact with the heart, I would be able to see some mapping of the heart and activation of that area. It is as if, imagine that there is a metal here in the room, and I have a metal detector. So I get the metal detector, I go do, 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 do. So I see where it is coming from, because this which shows me on the mapping system, and I would be able to go and dig the metal with what? With the catheter ablation. I go and burn that area or freeze that area. So that is what we do during the catheter ablation. Either we freeze it or we burn it. So like if there is AVNRT, majority of the time I freeze it, but you can burn it as well. Or if it is some area inside the ventricle, there is one area of the spike, so it is coming and it is causing some extra beats and stuff. It is kind of like a cat and mouse game. I have to find where the mouse is and get it. The majority of time they're outpatient procedure. Rarely, if we do like 3 or 4 procedures a day and we finish the last procedure at 4 p.m., I would prefer not to send the patient home at 8 p.m. So we keep the patient overnight, but majority of the rest of the patient, they go home the same day.
And then we're going to talk about pros and cons of this catheter ablation. The pros, for patients with ventricular tachycardia in absence of structural disease, uh, the risk of sudden death is lower than in bipolar ablation of ventricular tachycardia, in which 2 catheters are positioned on opposite sides of the ventricular wall has also been successfully used for ventricular tachycardia originating in deep locations. Now, in the terms of cons, among patients with structural heart disease, success rates are not as high, although technological advancements have resulted in improved outcomes. If ventricular tachycardia is not successfully controlled with catheter ablation, or if it recurs despite of ablation, the chance of survival is decreased. Then in Ecuador, the cardiac arrhythmia is a highly prevalent entity in the general population with a higher incidence in men, its diagnosis has increased exponentially since the use of electrocardiogram, since it has made it possible to detect cardiac arrhythmias. In 2014, a total of 4430 deaths from ischemic heart disease were reported, while due to heart failures, deaths reached 16, and cardiac arrhythmias take away a total of 168 lives.
Well, February is Heart Health Awareness Month. The Yukon Health Center has a program, though, that helps detect problems connected to the rhythm of the heart, and Dr. Chris Pickett is the co-director of the Heart Rhythm Program. Good morning. Thanks for coming on the show.
Sure,
pleasure to meet you.
Thank you.
First, let's just talk about the Heart Rhythm Program and really what it does.
Yeah, so we specialize in diagnosis and management of heart arrhythmias, which is an abnormal heart rhythm or an electrical problem with the heart. As opposed to people I think are more common with the concept of a heart attack,
right,
where you have a blockage in one of the arteries that feeds blood to the heart muscle. This is dealing with electrical problems of the heart.
So let's talk about heart arrhythmia. Is it genetic? What are the risk factors? How do you know if you're
so one of the enjoyable things about the field for me is that it really happens in many different people. So it can happen in young people, sometimes for genetic causes. Commonly it happens in people who have other heart conditions, have had heart attacks or have high blood pressure. It really sort of comes in the entire population.
But it doesn't have to be genetic. I mean, really.
No, not at all. No. There are some genetic conditions, but that's actually a relatively small proportion of the arrhythmias we deal with.
So how do you know? Like, what are symptoms? Are there symptoms?
Yeah, it's interesting. So there's lots of very different symptoms. Some of the most common arrhythmias actually come without any symptoms whatsoever and are important to diagnose because people can be at risk of a stroke because of those arrhythmias. People also can commonly have episodes of passing out, or they can have a sensation of palpitations where they feel that the heart's racing. They're just sitting there watching TV and it feels like they're running a marathon. You can have symptoms just of being tired and short of breath when you exert yourself for unclear reasons. It really can present in many different ways.
So if you're getting these symptoms, what should one do?
If you're concerned, the best thing is always to go to your doctor. The best way of diagnosing one of these conditions is having an EKG, which can be done in the doctor's office. It just takes a few seconds. Sometimes if the episodes are sporadic and happen intermittently, actually we have patients go home with portable heart monitors, which they can wear sort of for up to a month at a time sometimes to make the diagnosis.
So if someone's unfamiliar with this, a little scared to come in, talk about exactly what an EKG is. And if they come in, what's a normal one compared to something that's abnormal or life-threatening?
An EKG is just putting some electrodes on the chest, and it's a very quick and non-invasive way of measuring the electrical activity of the heart at that time. You have to go to medical school and learn how to interpret it, but it's really quite quick and easy to do, at least as an initial way of assessing people's symptoms.
Okay, and if one is abnormal, what do you do? What happens from there?
Well, it depends on the type of arrhythmia after you make the diagnosis. Some are just a nuisance, and you can just reassure the patient that this is okay, and this is something almost everyone has, and will never cause you any problems, but might cause you to have a symptom now and then. And some people are rushed off the emergency room right away because it can be potentially life-threatening in some situations.
If you have this, is this a case where you get like a heart defibrillator or something implanted into your heart?
Yeah, there's lots of different ways we treat them. So for some of the dangerous life-threatening arrhythmias, we actually put a defibrillator into patients, and that's an implantable device that goes inside the patient. So we're all familiar with watching ER and having paddles put on people's chests and having them shocked. And some people who are at high risk of having these life-threatening arrhythmias, you don't want to hope that they can get to an emergency room in time. So they have one of these implantable devices put in that's sort of an insurance policy that's there with them 24/7, 365.
Right. So for Heart Health Awareness Month, your best advice, even if you're having the smallest symptoms, it's better safe to come in and just get checked out, because no harm in coming in, right?
Not at all.
All right.
No.
Thank you so much, Dr. Chris Pickett. We really appreciate it.
Well, in conclusions, we have to talk about the ventricular arrhythmias are the most common cause of sudden death. They usually occur in patients with structural heart disease, catheter and in respect of the surgical procedure that catheter ablation is useful in preventing ventricular tachycardia recurrence, and for that reason, avoid and treat well and better the tachyarrhythmia. Currently, several clinical trials are underway comparing catheter ablation with antiarrhythmic medication, especially with amiodarone, to take care of this issue, and but it is still in search and investigation. Thanks.